So, good morning again. In the last part, we discussed about ABG. In that, we discussed about one part of ABG analysis, which is analyzing acids and bases. So, we didn't discuss much about the G, which is the gases component. So, ABG is actually arterial blood gases. But what we do usually is we only discuss about acidosis and alkalosis and CO2, but we fail to see another important component of ABG analysis, which is about the oxygen. Okay, so we'll be discussing some clinical aspects of the gases aspect. So again, basically gases means we have two gases, oxygen and carbon dioxide. So before we proceed, I'll just give a hint of what all we are going to discuss today. So I'll tell you about what is about FiO2. So what is PaO2, that is arterial oxygen. I'll tell you about a term called P capital AO2, which is alveolar oxygen. Then we have something called PF ratio. We have something called SF ratio. We have something called AA oxygen difference, arterial alveolar oxygen difference. We have something called as venous O2, venous oxygen, VO2. There's something called SVO2. I'll tell you what is that. And we'll be discussing some clinical examples like what are the causes of hypoxia and where these values are useful. And a few basic values. So last class we discussed about the normal value of PCO2 or arterial CO2, which is 35 to 45 millimeters of mercury. In average, we discussed that the average value is 40 millimeters of mercury. So similarly, we have arterial oxygen content, which is 80 to 100 millimeters of mercury. What is FiO2? It is the fraction of inspired arterial oxygen. So from time immemorial, from our school days, we have learned that the air contains 21% of oxygen. So when we are breathing room air, we inspire 21% of oxygen. So 21% is 21 by 100, or it is 0.21. So simply to say, FiO2 is 21%. So why this FiO2 is important? Suppose if you are keeping oxygen for a particular patient, the FiO2 varies. So we have a simple clinical formula for that. So you would have known about the oxygen delivery devices. We have nasal cannula, we have mask, and non-rebreathing mask. With the nasal cannula, we usually give 2 to 3 liters. When the oxygen requirement exceeds 2 liters, up to 10 liters, we use the mask. And when the oxygen requirement is more than 10 liters per minute, we use NRBM. So how does this one affect your FiO2? Roughly we say 1 liter will increase FiO2 by 4%. So assume that you are giving 5 liter of oxygen to a patient. It has to be given through mask. So how much is the increase? I told you 1 liter increases oxygen concentration by 4%. So 5 liters of oxygen will increase the oxygen concentration by 20%. So FiO2 is 21, or we take it as 24 is. This 5 liter extra oxygen will be 20%, so which is 40%. So you would have seen in your ICUs when we are analyzing ABG through the machine, we have to enter the FiO2. Only then we can get the correct gases analysis. So this is a simple way to assess the FiO2. If a patient is getting room air, it is 21%. If a patient is getting oxygen delivery devices by cannula, mask or NRBM, by the actual liters of oxygen he is getting, we can calculate the FiO2. If the patient is ventilated, things are easy because the ventilator itself has a setting called FiO2. So we can adjust the FiO2 from 21% up to even 100%. So this will help in calculation because we have a value called SF ratio, PF ratio, where FiO2 is must to know. So again, coming to the values, I discussed about arterial CO2 concentration, arterial O2 concentration, and FiO2, which is fraction of inspired oxygen. Now we are telling about A, right? Capital A, which is the alveolar gas concentration. Remember, alveolar carbon dioxide concentration is the same as arterial carbon dioxide concentration, so which is 40 millimeters of mercury, or in range it is 35 to 45 millimeters of mercury. But when you are calculating alveolar oxygen concentration, it is not so simple as this one. We have a formula for that. So the alveolar oxygen concentration comes with the formula. FiO2 into atmospheric partial pressure minus partial pressure of water vapor. So this comes as a full bracket, minus of arterial CO2. Arterial CO2 and alveolar CO2 both are same, divided by respiratory quotient. So we are not going to discuss the actual physiology. FiO2 is very important to know. Atmospheric pressure varies by the level which we are standing. For example, at sea level, the atmospheric pressure is 760 millimeters of mercury, which we have discussed in UG days. And the partial pressure of water vapor is 47. Again, PaCO2 is around 40. Respiratory quotient is usually respiratory quotient is calculated by carbon dioxide divided by oxygen difference. How much carbon dioxide is generated by consuming a particular amount of oxygen. It varies by the type of diet we take. For carbohydrate, fat and protein it is different. Again, we are not going to discuss the entire details. So if you know this formula, you can apply the values and calculate it. If you don't know the values, you can use calculators which are available in the net. But most latest ABG machines, they calculate PaO2 themselves by pre-recorded values. Okay, so just to know about PaO2. Now coming to the percentages. So what we discussed is the actual amount of carbon dioxide or amount of oxygen which is dissolved in the artery. That is called P small a O2 or P small a CO2. Alveolar oxygen or alveolar carbon dioxide is the amount of oxygen or carbon dioxide present in the alveolus or in the inspired air. It is enough to remember P capital A O2 alone, because P capital A CO2 and P small a CO2 both are equal. Then what about saturation? So before knowing the saturation, just a small technical point which you should remember is how does oxygen gets transported in the blood. Once we inspire air into the lungs, this process is called as ventilation. The process by which we take in oxygen and leave out carbon dioxide is called as ventilation. So once we get insulated with oxygen, in the lungs we have something called as the terminal alveolus and a respiratory membrane. Capillary is in close contact with the alveolus. So this small gap is the place through which gas exchange occurs. So oxygen enters from the alveolus to the capillary, and carbon dioxide enters from the capillary to the alveolus. So this process is called as exchange. We discussed this in one of our previous videos also. Like respiratory failure is of 4 types: type 1, type 2, type 3 and type 4. Type 1 and type 2 is very important to know. Type 1 respiratory failure is a problem with this exchange phenomenon, whereas type 2 respiratory failure is a problem with ventilation. So in type 2 respiratory failure, oxygen will be low, carbon dioxide will be high in the blood because oxygen is not taken in, carbon dioxide is not exhaled out. Whereas in a type 1 respiratory failure, the primary problem is exchange. So in exchange, automatically O2 is low, but carbon dioxide will not be high because the diffusion power of carbon dioxide is very high. So even if there is a problem with this respiratory membrane, carbon dioxide can diffuse into the alveoli and can get exhaled out. Okay, so this is how oxygen enters into the capillary. In the capillary, how does oxygen go about? Among all the oxygen which enters, the majority of the oxygen binds into the RBCs and gets transported. Few get dissolved in the blood. So basically speaking, oxygen gets transported in blood mainly by 2 ways. One is through the hemoglobin, by binding to hemoglobin to form oxyhemoglobin, and by direct mixing with the blood. All the values which we have discussed till now, which is PaO2, that is the oxygen concentration of blood, is the actual oxygen which is present in the blood itself. It does not measure the oxygen which is bound to hemoglobin. And I already told you, compared to the dissolved oxygen in the blood, the oxygen carrying capacity of blood is more important in oxygen transport. Oxyhemoglobin, this is not measured directly. So how this is measured is by a value called as saturation. So you know very well, hemoglobin has 4 arms. So each 4 heme arms, which can bind 4 molecules of oxygen. So when through the oxygen, when it goes into the capillary, 1 oxygen is extracted, and the venous blood, in the venous blood, we have deoxyhemoglobin, where among the 4 arms only 3 have oxygen. Which means in the arterial side, the hemoglobin is 100% saturated. All 4 arms are filled with oxygen, whereas in the venous side, only 3 is filled. So 75% is the normal venous oxygen saturation. Again, people have given a range. Technically, practically, it's 90 to 100 can be taken. Some say it is 95 to 100 is normal oxygen saturation. Normal venous saturation, maybe you can take it as 70 to 80%. 70 to 80% is the normal venous saturation. So now what is this difference? So we have arterial oxygen saturation, we have venous oxygen saturation. The difference is arterial venous oxygen saturation difference, which is 100 minus 80, around 20%. Again, if you go deep into physiology, they say 20 ml of oxygen is present in arterial side, 15 ml of oxygen is present in venous side, which means 5 ml of oxygen is extracted by tissue. So the arterial venous oxygen difference is actually 5 ml of oxygen. Again, this is not practically measured, so it is enough to remember the arterial venous oxygen difference, right? So one important point to remember from this basic physiological concept is, what we measure in ABG is the dissolved oxygen is in blood, which is PaO2. But what is even more important is the oxygen which is bound to hemoglobin as oxyhemoglobin, which is given as saturation. So when hemoglobin drops, oxygen carrying capacity of blood drops, it leads to hypoxia. We will be discussing it a bit later. Just know this basics now. Okay. So I think we have discussed all the basics now. So just to recall the terms which I discussed till now, P small a O2 is the dissolved oxygen in blood, which is 80 to 100 mm of Hg. The PCO2, need not worry about whether it is small a or capital A. The common value is 35 to 45 millimeters of mercury. P capital A O2, alveolar O2, is the amount of oxygen which is present in the air. Why to know it, I'll tell you later. And FiO2 is fraction of inspired oxygen. Normally in room air it is 21%, and based on oxygen the patient is getting, we have to calculate the FiO2. Okay. So with this basics in mind, let us continue with our interpretation of ABG. So once you have finished analyzing the acids and bases, we have to analyze the gases. So as usual, we can see the CO2. I told you the normal PCO2 is 35 to 45 millimeters of mercury. If it is more than 45 millimeters of mercury, what does it mean? Patient is having respiratory acidosis. Patient is having respiratory acidosis. When CO2 has to accumulate, it means that patient is hypoventilating. He is not able to inspire oxygen. He is not able to expire out carbon dioxide. So patient is hypoventilating. In other words, it is type 2 respiratory failure. This we have discussed in our previous videos. So what are the examples we can tell for type 2 respiratory failure is, one patient is in anesthesia. Classical example. We are knocking off the central nervous system, patient's respiratory drive is lost. Or we are over sedating a patient. So their respiratory drive is lost, PCO2 can increase. Or patient is having some respiratory disease, neuromuscular disease. So they can't, their muscles are not so strong to take in oxygen or to expel carbon dioxide. Then we have a respiratory disease, which is an airway disease. Please remember, the function of airways is to take in oxygen and leave out carbon dioxide. The function of alveolus is to exchange. So when there is a problem with the airway, it leads to a ventilation issue. So oxygen falls and CO2 rises. Whereas when there is a problem with the respiratory membrane, like the alveoli alone, carbon dioxide is not much affected, oxygen alone gets affected, leads to type 1 respiratory failure. So the example for airway disease is COPD. Bronchiectasis. So these are lower airway diseases. Regarding upper airway diseases, we have obstructive sleep apnea, where the larger airways become small because of fat accumulation, which occurs in obesity. So that is also an airway disease. So these are common examples for type 2 respiratory failure. Okay. So when CO2, plus we also discussed about acute respiratory acidosis and chronic respiratory acidosis. We have separate formulas for that, how to find out whether it is acute respiratory acidosis or chronic respiratory acidosis. But for practical purposes, acute respiratory acidosis, some disease comes on acutely. For example, there's a COPD acute exacerbation, or we are giving a sedation, or he has gone in for a patient with myasthenia, has suddenly gone in for myasthenia crisis. So these are acute respiratory disorders. When we say chronic respiratory acidosis, he has a disease for a longer time. Example, a chronic COPD, a chronic OSA. One simple practical tip is, when things become chronic, compensation occurs. And if you remember from our previous class, when CO2 increases, compensation occurs by the same direction rule, by increasing the bicarbonate. So when acidosis becomes chronic, when CO2 elevation becomes chronic, bicarbonate also increases. So when there is a patient having a normal pH due to compensation, but the PCO2 is higher than normal and the bicarbonate is higher than normal, this usually means a chronic compensated respiratory acidosis. Just a practical tip, but there are separate formulas which we are not going to discuss since this is a practical class. So this is about acute respiratory acidosis. So when PCO2 is less than 35 millimeters of mercury, again you know very well it is respiratory alkalosis. Again we have acute respiratory alkalosis, chronic respiratory alkalosis. So where does this respiratory alkalosis come? Usually it comes as a compensation for metabolic acidosis by the same direction rule. When bicarbonate falls, our body tries to compensate by excreting acid, which is carbon dioxide. So this is the common scenario we see. Patient is having a metabolic acidosis like a diabetic ketoacidosis, lactic acidosis, or CKD acidosis, or some poisoning acidosis. As when bicarbonate falls, patient will be tachypnic, the so-called Kussmaul's breathing, to reduce CO2. This is acute respiratory alkalosis. Maybe we can say chronic respiratory alkalosis occurs as a compensation for chronic acidosis, as in renal tubular acidosis. Right? Patient is having acidosis for a longer time, a mild acidosis, so maybe CO2 will be low. So usually here patients will be tachypnic. In respiratory acidosis, I told you something is reducing ventilation, so patient's respiratory drive is lost, respiratory rate will be low. Whereas in respiratory alkalosis, especially acute respiratory alkalosis, patients will be tachypnic to exhale. Okay. This is high altitude. So these are some common examples for respiratory alkalosis. So I think CO2 is very easy to remember because few things we have discussed in the last class itself. Now coming to oxygen. So we have discussed about PCO2, which is not in the list. So FaO2 also we can give a tick because we have discussed it while discussing the basics itself, FaO2. Now coming to oxygen, PaO2, P small aO2, which is the dissolved oxygen in blood or the arterial oxygen concentration. So as I already told you, the normal value is 80 to 100 millimeters of mercury. So when it becomes less than 80, we call it as hypoxia. So from your physiology, there are 4 basic types of hypoxia. Hypoxia is low tissue oxygen concentration. One is hypoxemic hypoxia. Anemic hypoxia. Stagnant hypoxia, histotoxic hypoxia. So this is something which we have learned theoretically from our physiology. We'll just make it more practical. So hypoxemic hypoxia is the tissues are getting less oxygen because of low oxygen in the blood. I already told you how does oxygen enter the blood? Through the airways. So hypoxemic hypoxia is there is hypoxia, low oxygen delivery to the tissues because of low inspired oxygen. So can you tell me examples where inspired oxygen is low? One is actually high altitude. Next is again respiratory diseases or airway diseases which cause low oxygen. So maybe you can tell diseases, like airway diseases, which we have discussed, like COPD, bronchiectasis, etc. Third place where oxygen is low in the blood is pulmonary embolism. So this is called as ventilation perfusion mismatch. What is pulmonary embolism is I already discussed. Air enters from alveoli into the blood. How does the pulmonary capillary form? From the pulmonary artery. Pulmonary artery is a branch from the right ventricle. So what is pulmonary embolism is some blood clot is occluding the main pulmonary artery or a branch of the pulmonary artery. So when the pulmonary artery gets occluded, blood does not flow from the right ventricle to the pulmonary capillaries. So even though there is more oxygen entering the capillary, since there is a blockage in the pulmonary artery, there is not adequate blood to reach the pulmonary capillary. So the minimum amount of blood which is reaching the pulmonary vein has low oxygen concentration, right? Pulmonary artery, pulmonary capillary, pulmonary vein. Pulmonary artery is occluded, so low amount of blood flows to the pulmonary capillary. Hence, the amount of blood coming out also has low oxygen. So even though there is a ventilation, the perfusion is defective. Why this is important to know is, even though you give plenty of oxygen to correct this low oxygen, it doesn't get corrected because the blood itself is not flowing into the capillaries. This is the simple basis of pulmonary embolism, right? The fourth example of hypoxia is shunt physiology. Again, shunt is, we have pulmonary capillary, alveoli, we have the pulmonary artery coming in, we have the pulmonary capillary which is forming, and the pulmonary vein which goes out. So this is the normal pathway. Assume due to some reason the blood doesn't flow from the pulmonary artery to the pulmonary capillary. Instead, there is a direct connection between the pulmonary artery and pulmonary capillary. This is called a shunt. So even though there is plenty of oxygen in the alveolus, there is no use because whatever deoxygenated blood is there in the pulmonary artery directly gets communicated with the pulmonary vein and it enters the systemic circulation. You know very well, this pulmonary veins are 4 in number. They go into the left atrium to the left ventricle and gets pumped out to the aorta. So this is the shunt physiology. So where does this shunt occur? Since we are dealing with practical things, I'll give you a practical example. Patients with pleural effusion. So in patients with pleural effusion, what happens is their lungs become collapsed. Okay, so assume this is the thoracic cavity. There is fluid around. So it is compressing the lung. Only this part of the lung is ventilating. When such a thing occurs, there will be hypoxia in the surrounding lung. You would have heard a compensatory mechanism called hypoxic vasoconstriction. Hypoxia causes vasodilatation everywhere in the body except in the lungs, where it causes hypoxic vasoconstriction of the pulmonary artery. This is actually a protective mechanism. So why this is a protective mechanism? When some problem like a lung collapse or effusion compressing the lung occurs, part of the alveoli become collapsed. So those places are not receiving oxygen. When oxygen is not there, but blood flow alone occurs, it is actually a shunt, right? Because blood flow is, alveolus is not getting ventilated, which means there is no oxygen. So when the blood comes from the pulmonary artery and it crosses the pulmonary capillary to vein, it is not getting oxygenated, which is typically like a shunt. Alright, so to counteract this mechanism, there is hypoxic vasoconstriction. The pulmonary arteries also get constricted, so blood flow does not occur to the hypoxic or a collapsed alveoli. So this is a mechanism to protect the shunt which can normally form when there is a lung atelectasis. When does this hypoxic vasoconstriction fail? When we are giving some vasodilators for some other reason. For example, diltiazem is a vasodilator. Nitrates are vasodilators. So assume that this effusion is due to a cardiac failure and effusion is there. If you are giving a vasodilator, what happens? There is a hypoxic vasoconstriction due to shunt, a hypoxic vasoconstriction due to lung collapse and pleural effusion, which tries to protect further shunt formation. But on giving vasodilators, this mechanism is offset. The pulmonary artery opens, capillaries get the blood flow, which is not oxygenated. So the deoxygenated blood directly joins the vein. So it is like a shunt mechanism. So this is one practical place where we use shunt. Again, to be theoretical, shunt is of two types: intracardiac shunt and extracardiac shunt. Example for intracardiac shunt is patient is having an ASD or a VSD or a patent foramen ovale. Even though these diseases are rare, like PFO may open when the right-sided lung pressures are high, right-sided cardiac pressures are high. This is called intracardiac shunt. We have extracardiac shunt. So this is one example for extracardiac shunt. So a patient with pleural effusion receiving vasodilators. Another place where the shunt occurs is hepatopulmonary syndrome. Liver is a place which detoxifies many toxins. But in liver cirrhosis, those detoxification does not occur and more nitric oxide enters the blood as a result of this failed detoxification. Nitric oxide, as you know, is a vasodilator, as we discussed in nitrates. So this nitric oxide keeps the arteries open. Also in hepatic failure, there can be basal effusion. Bilateral pleural effusion can be there, so the same mechanism occurs. So even though there is an effusion which is compressing the base of the lung, causing atelectasis, because of vasodilators, there will be vasodilatation of the basal parts, which causes shunt. That is, deoxygenated blood directly enters from artery to the vein. Okay, I'll just erase off these things. What you have to know is there's something called shunt physiology. It is not theoretical, we can see it practically also. So where we see it practically is, as I already told the patient with heart failure, effusion, we are giving oxygen, their saturation doesn't improve, we have tried every best mechanism, it could be shunt. Okay. So anemic hypoxia. I already told you, oxygen carrying capacity, oxygen transport in blood is mainly by two mechanisms. The main mechanism is through hemoglobin. The other mechanism is by dissolved oxygen. So what we discussed, these four causes is there is low oxygen in the alveolus, so the dissolved oxygen is low. The second scenario is anemic hypoxia. The inspired oxygen is normal. The ventilation is normal. Oxygen enters the pulmonary capillaries normally. But what happens because of anemia, low hemoglobin, the oxygen carrying capacity of blood itself is low. Right? So some say diseases like methemoglobinemia, abnormal hemoglobin. It also comes into anemia. And even plain anemia itself can cause anemic hypoxia. Stagnant hypoxia, the classical hypoxia. So in stagnant hypoxia, the ventilation of oxygen is normal. Oxygen is perfused to the tissues. The ventilation is normal. There is no anemia also. But what is meant by stagnation? The blood is not transported to the tissues properly. In other ways, it is called a shock. So we'll discuss shock later in another class also. So stagnant hypoxia is oxygen is normal, hemoglobin is normal, but the oxygen is not reaching the tissues properly. So the classical example here is shock. Example is heart failure. We have many types of shock: hypovolemic shock, cardiogenic shock, and even septic shock. Remember, sepsis causes another type of hypoxia, but septic shock, perfusion is low, it causes stagnant hypoxia. So what happens in stagnant hypoxia and what happens in anemia? One peculiar thing happens. So when oxygen is delivered to the peripheral tissues, when there is anemia or when there is heart failure, the perfusion is low or the oxygen which is delivered itself is low. So what do the tissues do? The tissues try to extract as much oxygen as possible to survive. So the extraction of oxygen becomes more. So I already told you, the arteries deliver about 20 ml of oxygen. The tissues consume 5 ml of oxygen. So the veins will carry the remaining 15 ml of oxygen. So what happens when shock is there, or when there is stagnant hypoxia, or when there is anemic hypoxia? The tissue extraction becomes more, which means even though the arteries deliver 20 ml of oxygen, the tissues extract more amount of oxygen and the veins carry less than 15 ml of oxygen. So we do not calculate ml practically. So the arterial oxygen saturation is 100%. The normal venous oxygen saturation is 75 to 80%. In stagnant hypoxia or in anemic hypoxia, what happens? The tissue extraction is more. So when the tissue extraction is more, the veins will carry lesser amount of oxygen. So it will carry less than 75%. So arterial venous oxygen saturation difference becomes very high. Right? So till now we are discussing about ABG, arterial blood gases. Here comes an important concept called as venous blood gases. Okay, how? Because only when we measure the venous blood gases, we can find out the venous oxygen saturation, right? So usually venous blood can be taken from peripheral vein, but we usually take it from central vein. The central vein can be superior vena cava, or in advanced centers, they insert it through a central line. They insert a catheter called Swan-Ganz catheter, and they take it from the pulmonary artery itself. So pulmonary artery is basically a mixture of both, right? SVC blood and IVC blood. So it is called as SVO2. SVO2 is mixed venous oxygen difference. Like it measures the oxygen concentration in venous blood. The venous blood here, why it is mixed? It measures the mixed blood of both SVC and IVC. That is both upper body and lower body. Oxygen difference. Okay. So I have just introduced you to the concept of mixed venous oxygen difference. Okay, why this mixed venous oxygen difference or SVO2 is important? Now the last type of hypoxia is histotoxic hypoxia. what happens in histotoxic hypoxia? The oxygen is ventilated normally, perfusion is normal, oxygen is transported to the tissues normally, but there is some problem in the tissues like a cyanide poisoning. Because of this, the tissues do not take oxygen. Everything is normal, but the tissues don't consume oxygen. So what happens to the AV oxygen difference here? The tissues don't consume oxygen. So even though the arteries deliver 20 ml of oxygen, the veins also carry the same amount of oxygen because the tissues do not consume that much of oxygen. Or rather than telling 20, we can tell the tissues consume less than 5 ml of oxygen, so the veins will have more than 20 ml of oxygen, which means the arterial venous oxygen difference is low. Okay, so arterial venous oxygen saturation difference is high in cases of stagnant hypoxia, especially in heart failure, and the AV oxygen difference is low in cases of tissue toxicity like cyanide poisoning. Remember methemoglobinemia. In methemoglobinemia, oxygen is not getting released from the methemoglobin. Okay, methemoglobin is an abnormal hemoglobin, occurs due to certain poisoning. In this poisoning, oxygen is not getting released from the hemoglobin. Similar thing occurs in carbon monoxide poisoning. Even though oxygen binds to the hemoglobin, oxygen is not getting released into the tissues. So here again what happens? The venous oxygen will be high. So arterial venous oxygen difference will be low. Correct? So to discuss hypoxia, you should know something about this AV oxygen difference. Now since we are told about AV oxygen difference, I will tell you about another parameter, which is A oxygen difference. So AV oxygen difference helps to differentiate between the stagnant causes of hypoxia and histotoxic causes of hypoxia, whereas A oxygen difference helps to differentiate between the different causes of hypoxemic hypoxia. So I told you about 4 causes of hypoxemic hypoxia. One is high altitude, next is COPD, third is pulmonary embolism, which is a perfusion mismatch. Ventilation is normal, perfusion is abnormal. Next is shunt physiology, where perfusion is normal but ventilation is abnormal. So ventilation of alveoli is abnormal, so blood is not getting oxygenated. The deoxygenated blood directly mixes from the artery to the vein. So only this A oxygen difference can help to differentiate. So normally it is said that there's a formula to calculate the normal difference or normal AA gradient. They are given just a rough formula, AH plus 10 divided by 4. So this is a normal AA gradient for some person. So most ABGs calculate this AA gradient also. Even if it is not given, we can calculate the alveolar oxygen using the formula given above, and we can subtract it from the arterial oxygen if it is more than this value. But some people say we can take up to 20 as normal. So up to 20 millimeters of mercury is the normal AA gradient. So how does this AA gradient help us? In high altitude, what is the main problem? There is low inspired arterial oxygen itself. So alveolar oxygen is low. Because of that, the arterial oxygen is low. So the gradient remains normal. What happens in COPD is inspired itself is low. Right? So what is inspired is getting exchanged. So COPD is also similar to the high altitude because the inspiration itself is low, right? So the inspiration itself is low. So the AA difference is basically normal. The inspiration is low, hence oxygen is low. What happens in pulmonary embolism? Here there is a ventilation perfusion mismatch because the inspired oxygen in air is normal. The normal air is getting inspired, but that oxygen does not reach the tissues because there is a block at the level of the pulmonary capillaries. So here PaO2 is normal, whereas the arterial oxygen is very low. PaO2 is normal, oxygen is very low. So AA gradient is increased more than 20. What happens in shunt physiology? Shunt physiology is the same. The inspired oxygen is normal, but there is hypoxia because oxygen does not enter into the pulmonary capillaries. So the venous blood, the pulmonary venous blood actually has deoxygenated blood, which is arterial oxygen. The pulmonary venous blood is actually arterial oxygen, it is low. So AA gradient is increased. So to differentiate 4 causes of hypoxic hypoxia, this AA gradient is useful. So AA gradient can be normal or AA gradient can be increased. So AA gradient is normal in conditions of high altitude or COPD. Whereas it is high in terms of pulmonary embolism or shunt. Okay, so why this is important to differentiate is, if the alveolar arterial oxygen difference is normal, okay, this can be correct. If it is normal, what does it mean? Oxygen is low because inspired oxygen is low. Blood oxygen is low because inspired oxygen is low. So the gradient is normal. This can be corrected by giving supplemental O2. So you would have seen in your ICU practice, patients with COPD, even though they are very breathless, their hypoxia rapidly improves on giving O2. You need not give high oxygen at all. Their saturation improves dramatically with the low oxygen concentration. Whereas when there is pulmonary embolism or shunt, the inspired oxygen or the arterial oxygen is, alveolar oxygen is normal, but the inspired alveolar oxygen does not enter into the pulmonary capillaries. Hence, the arterial oxygen saturation is low or the AA gradient is increased. So they say it is increased more than 10 to 20 millimeters of mercury. This will not respond to O2 because alveolar oxygen is already normal. There is no point. Either you have to correct the shunt or you have to correct the pulmonary embolism because these two are ventilation perfusion mismatch. Right? So this took so much of time, but I wanted you to be clear with the concept because this is a place where many of us get confused. So we'll just summarize this oxygen concept alone quickly. So we'll just discuss oxygen aspect quickly. So the normal PO2 is 80 to 100 millimeters of mercury. The normal arterial saturation is 95 to 100%. The normal venous oxygen saturation, also called as mixed venous saturation, is 75 to 80%. Why it is called mixed venous saturation? It is measured from the right atrium or the pulmonary artery, which carries blood from both SVC and IVC. Okay, it is called mixed venous oxygen saturation, but it is commonly represented as SVO2. Then A oxygen difference, the alveolar arterial oxygen gradient. So the normal gradient is H plus 10 divided by 4, or the danger value or critical value is taken to be 20. Normal AA oxygen gradient is less than 20 millimeters of mercury. If it is more than 20 millimeters of mercury, it is increased. Next is AV oxygen difference or arterial venous saturation difference. Again, it comes around 20%. Okay. So where does all this help clinically? To differentiate the 4 causes of hypoxia. So the 4 causes of hypoxia are hypoxemic hypoxia, where there is hypoxia because the blood is not, the oxygen is not entering the lungs, or the oxygen which enters the lung does not enter into the blood. The next is anemic hypoxia, where the oxygen in the air is normal, the oxygen enters into the lungs normally, the oxygen is getting exchanged normally, but it is not carried properly because the oxygen carrying capacity is low due to anemia. The third is stagnant hypoxia, where ventilation is normal, perfusion is normal, oxygen carrying capacity of blood is normal, but because of low perfusion as in shock, there is hypoxia, low oxygen delivery to the tissues. Last is histotoxic hypoxia. Histotoxic hypoxia is the oxygen is ventilated normally, perfused normally, delivered normally, but the tissues do not extract oxygen because tissues are damaged either due to cyanide poisoning or sepsis. So remember, septic shock, that is stagnant hypoxia, but sepsis is actually histotoxic hypoxia. This hypoxic hypoxia can occur due to 4 reasons. One is due to low inspired oxygen as in high altitude. Second is airway diseases like COPD. Third is which is ventilation perfusion mismatch. Ventilation is normal, but because of a block in the pulmonary arterial system, no blood comes through the pulmonary capillary, hence it is not ventilated. Then we have something called a shunt. Example is a pleural effusion case with a vasodilator in place, where or a hepatopulmonary syndrome, where because of vasodilatation, pulmonary arterial blood directly goes into the pulmonary venous system without getting oxygenated. So to differentiate this hypoxia, we have 2 parameters, which is A oxygen difference. In high altitude or COPD, the alveolar arterial oxygen difference is normal because the inspired alveolar oxygen itself is low, hence arterial oxygen is low. Whereas in pulmonary embolism or shunt, the alveolar oxygen is normal, but the arterial oxygen is very low, hence this AA oxygen difference is, AA gradient is high is more than 20 millimeters of mercury. Whereas another parameter which helps us to differentiate anemic, stagnant and histotoxic hypoxia is the arterial venous oxygen difference. So the normal arterial venous difference is 20%, or 5 ml of oxygen. So where does it increase? It increases in situations where the tissue extraction is very high, hence the arterial oxygen is normal, but the venous oxygen is very low. So AV oxygen difference is more than 20%, especially in conditions of anemia and shock, including septic shock. And where this AV oxygen difference is low, it is low in conditions where peripheral oxygen utilization is less. So venous oxygen becomes high. So AA oxygen difference is saturation is less than 20%. This occurs in conditions like cyanide poisoning, and methemoglobinemia, carbon monoxide poisoning. How to find out this is you have to take both arterial blood and venous blood. We have another marker which is mixed venous oxygen saturation. So in conditions where AV oxygen difference is high, it is actually mixed venous oxygen saturation is low because tissue extraction is very high. Whereas in places where tissue extraction is very low and AV oxygen difference is low, it means the mixed venous oxygen saturation is high. Right? So when we take an ABG and a VBG in these situations, we can help to differentiate the various causes of hypoxia. Right? So in VBG, we can calculate venous oxygen saturation. If venous oxygen saturation is high, it means there is cyanide poisoning, methemoglobinemia, or CO poisoning. From the same ABG, VBG, we can calculate the arterial venous oxygen difference. Right? In conditions of anemia, shock, and septic shock, the same SvO2 becomes very low, whereas AV oxygen difference becomes high. So remember, in sepsis, SvO2 is high, whereas in septic shock, SvO2 is low. So this finishes the major and the toughest part. So we have discussed about PaO2, arterial O2, the alveolar arterial gradient. We have discussed about the mixed venous oxygen saturation and AV oxygen difference. And we have discussed the various causes of hypoxia. Now just the last few minutes. PF ratio. How to quantify hypoxia. So you have learned in your previous classes that ARDS, in acute respiratory distress syndrome, we have something called as Berlin criteria. So Berlin criteria is basically three things. Patient is having hypoxia. They are given something called as PF ratio. PF ratio is PaO2 by FaO2 ratio. Dissolved oxygen concentration divided by FaO2 concentration. It is normally more than 300. If it is less than 300, it is one criteria for ARDS. It means lungs are damaged or problematic. Plus they have given a grading. More than 300 is normal. So if the PF ratio is 200 to 300, it is mild ARDS. The PF ratio is between 100 to 200, it is moderate. PF ratio is less than 100, it is severe ARDS. Okay, so the other criterion, Berlin's criteria is there is a low PF ratio, then patient is having some lung opacities, and the third criteria is symptoms less than 1 week of issue onset. Like patient has a pneumonia or fever, within 1 week he develops a hypoxia. It is called ARDS. So basically three criteria. One criteria is a clinical criteria. Patient has worsening respiratory distress within 1 week of clinical insult. Next is imaging criteria, where there are bilateral lung opacities which is not explained by a lung disease like effusion, collapse or nodules. And third is a lab criteria, PF ratio. And ARDS is also called as non-cardiogenic pulmonary edema. So just remember this value. All of this along with pulmonary capillary wedge pressure is less than 18 millimeters of mercury. We'll discuss this maybe in another class. Just remember the criteria. This PF ratio needs an ABG, right? But in few places ABG is not that accessible. It may take time to quantify PF ratio. So we have another ratio called as SF ratio, which is saturation FiO2 ratio. So the normal SF ratio is more than 315. So if it is less than 315, again it means it is ARDS. So here again we can quantify, like if the SF ratio is 235 to 315, it is mild ARDS. So less than 235, I think it is around 120 to 235, it is moderate ARDS. Less than 120, it is severe ARDS. Right. So I know this is a bit tougher concept, but since it is very important, we spend so much of time discussing. So we'll just make a quick summary of what we discussed today. So when we see about the gases analysis in ABG, better it is ideal to do an arterial blood gas and a venous blood gas at the same time if clinically warranted. So first thing is to see is the PCO2. If PCO2 is high, it means there is a respiratory acidosis. Either it's an acute respiratory acidosis due to neuromuscular dysfunction or some airway diseases, or it is a chronic respiratory acidosis which is compensated. If PCO2 is low, it is called respiratory alkalosis. Again, it may be acute respiratory alkalosis or a chronic respiratory alkalosis. Acute respiratory alkalosis usually occurs as a compensation to metabolic acidosis. This manifests as hyperventilation. Chronic respiratory alkalosis usually occurs in high altitude. And third, we discussed about PO2. So when PO2 is low, it is hypoxia. So how to quantify hypoxia in ARDS, especially it is by PF ratio or SF ratio. So PF ratio, if it is less than 300, it means it is ARDS. SF ratio, if it is less than 315, it means ARDS by criteria. But to know the cause of hypoxia, when the PF is low, we actually have to calculate the alveolar arterial oxygen difference. So normal alveolar arterial oxygen difference is calculated by the formula H plus 10 by 4. If the AA oxygen difference is more than 20 or AA oxygen difference is less than 20, that is if it is, you just have to see whether if AA oxygen difference is high or if it is normal. If AA gradient is normal, it means the hypoxia is either due to hypoventilation due to an airway disease, or it means low inspired alveolar oxygen, which is like in high altitude. When this AA gradient is high, it means the inspired oxygen is normal, the ventilation is normal, but the perfusion is problematic, as in pulmonary embolism or a shunt. So why to know this difference is, if the AA oxygen difference is normal, they will dramatically respond to O2. Whereas if AA gradient is high, they will not respond to O2. So we have to find out the cause, whether it is a pulmonary embolism. So we have to send D dimer. Okay, there's a test called CT pulmonary angiogram. Only when you thrombolize or when you give anticoagulant, pulmonary embolism will improve. And if it is a shunt, I already told you, avoid vasodilators, and we may have to use vasoconstrictors. And so one we saw the PF ratio, second we saw the AA gradient. The third thing to see is mixed venous oxygen saturation. So if mixed venous oxygen saturation is very low, less than 75%, it means peripheral oxygen extraction is very high. Example, in conditions like anemia and stagnant hypoxia, that is any case of shock, heart failure, including septic shock. The same venous oxygen saturation, if it is high, more than 75%, it indirectly means that the peripheral tissue extraction is low. So they may have a cyanide poisoning or carbon monoxide poisoning or a methemoglobinemia. So once we have SvO2, we calculate something called AV oxygen difference. The same thing when arterial venous, when SvO2 is low, arterial venous oxygen difference is high, more than 5 ml of oxygen or more than 20%. So the same conditions of anemia, shock, heart failure and septic shock. When AV oxygen difference is low, when AV oxygen difference is low, it means venous oxygen saturation is high. So examples are this poisoning. Now we have a surrogate for high AV oxygen difference or a low venous oxygen saturation, which is lactate. So we may discuss lactate in another class. So I think this is a short summary of what we discussed entirely today. Thank you. We'll continue our emergency medicine series with another interesting topic next week.